Hey everybody, it's Stahlman again. I'm the host of The Doctor's In Live with TOA. It's Friday. Welcome back. We're back in the studio, just me this time. Thanks for supporting all the folks that we've had on. Dr. George's visit was one of our most popular ever. She's very competitive, so she likes that. But I hope that the information we're providing is good. I hope it's interesting. We're trying to vary the topics a little bit. So if you have any interest in a topic, please feel free to email us, or you can comment below and we can try to get somebody on the schedule. You certainly don't want to be looking at my face all the time, and I'd love to have other people from TOA participating. We are planning probably this next quarter or so to actually go on the road and visit some of the docs and some of the other offices, make it a little bit easier for them to be able to participate as well. So we're looking forward to that. Anyway, today, well, before I start, remember, I'm an orthopedic surgeon. I'm fellowship trained and board certified, but I am not your orthopedic surgeon, at least today. This information should be considered for education and informational purposes, maybe a little entertainment, but not medical advice. So if you have a problem, go to TOA.com. You can learn about TOA, learn about our physicians, learn about our services, our locations. You can even start the process of making an appointment online. You can start getting the process going about telemedicine appointments, which I did a couple of telemedicine visits this morning, as a matter of fact. So we're still doing that as well. We are in the process of updating and upgrading our website, some social media platform things. So look for a little bit of changes, a little bit of differences. One of the things that's really neat that's going on right now is we're putting out a bunch of content called TOA tips. They're little simple snippets of information from a variety of practitioners. They're super well done, as a matter of fact. And I think they can be very helpful for you. So all that stuff's on our website, TOA.com. The videos and such are in the media center section. So I hope that's helpful. Anyway, today we're going to talk about something that's pretty interesting to me. It's a problem that has been known about forever. In fact, it was probably one of the earliest thoughts of why low back pain happens way back in the early 19th century. And it really, treatment for this problem, sacroiliac joint pain and dysfunction, has really come full circle. And we actually have technologies nowadays that can really help people without really making it hard on them. So we're going to talk about the sacroiliac joint. We're going to talk about what it is, why it's a problem, what can cause that kind of problem, and then we're going to talk about some treatments for it, and we're going to end with a little bit of surgical treatment for it, because that's what's really exciting. So, as always, I like to try to give people a little bit of an anatomy lesson first. The sacroiliac joint, or also known as the SI joint, is a very, very, very complicated, stout structure. And having Kevin help us here, the sacroiliac joint is the space right here where your pelvis, this is that pelvis bone here, attaches to this triangular shaped bone, which is called the sacrum. And there's these joints right here and here in the backside. So this is his backside. Just like every other joint, you know, we've talked with Dr. Crook, we've talked with Dr. Willis, we've talked with Dr. Carpenter about joints and arthritis, and we've learned a little bit about articular cartilage, the bearing surface. If you don't remember those or didn't see those visits, for example, go back to last week's episode where we talked to Dr. Crook about cartilage restoration technologies. But essentially, the sacroiliac joint is a joint like your knee, your hip, your shoulder, which has cartilage in it. It moves. It's got a thick ligament structure around it to hold it together. It is different, however, in that it doesn't move like the hip, knee, or shoulder. It's basically, I tell patients, it kind of looks like my knuckles put together, and it can wiggle a little bit this way, it can flex a little bit this way, it can jog up and down, but it doesn't have very much motion in it. But the important thing to the sacroiliac joint is that it is a primary, probably the major weight-bearing area in your body. When you stand up on one leg, So as he's standing up on his left leg, the force of body weight up here and the force of gravity down here on the floor, everything concentrates through the sacroiliac joint. So you can imagine that if you've got a bad sacroiliac joint, every time you take a step or every time you move, you actually put a lot of stress through that joint and can be very painful. So it's an important joint. It's not very well understood. It's a joint like every other joint that can develop arthritis, it can develop inflammation, it can be traumatized, and it can cause pain. Now, the trouble with the sacroiliac joint is many times, as we talked about earlier in one of our first episodes, low back pain is super common. Unfortunately, if I took a 6-inch circle in the lower back, which is the most common area we see back pain, and centered it over the area of pain, there's a lot of structures in there that can cause pain. The joints of the spine, the discs, the nerves, the muscles, the ligaments, the sacroiliac joint. And it's sometimes really hard to tell what part of the body is causing pain. So the challenge with the sacroiliac joint is it's not always all back pain is related to the sacroiliac joint. We also have to remember that sometimes the sacroiliac joint is really the cause of the back pain rather than other things in the spine. And again, the challenge is making that diagnosis. So first off, anatomy. One thing about the sacroiliac joint that's really important is it's super rigid. It's held together by a substantial complex of ligaments that are very strong. And so to tear apart the sacroiliac joint, for example, in trauma, requires a tremendous amount of energy. So if somebody comes in the trauma unit at Vanderbilt and has a sacroiliac joint disruption, they have had major trauma, and it can be significantly problematic for the patient down the road. The anatomy. So what are the symptoms? Well, typically it's back pain. Typically it's pain kind of in the back of the spine, down low, over the buttock many times, and then occasionally that pain can radiate down into the hip, down into the upper thigh, even down past the knee, and occasionally people will complain of groin pain as well. Many times it's related to walking or twisting, lying on the side, rolling over in bed is another one. And the reason why it hurts in so many areas is because there's actually a lot of nerves around that area. So one of the big nerves called L5, which comes out between the bottom bone called L5 and S1, which is the top of the sacrum, runs right over the top of the sacroiliac joint. So if that joint is inflamed, even though the nerve's not getting squeezed on, it can be inflamed as well, and people can have pain down the pathway of that nerve, which is down the side of the leg. And so you can see that a ruptured disc causing pressure on the L5 nerve can cause you back pain and leg pain. But no pressure on the nerve, but irritation of the nerve from the sacroiliac joint can cause very similar symptoms. And that can make it very challenging to say, well, what is the cause of this? Is it a pinched nerve problem, or is it nerve irritation? And that's where a lot of expertise, a lot of experience, as well as imaging studies can be a help. Many times, however, because the sacroiliac joint is not well understood, a lot of physicians, primary care physicians who don't have much experience with it, some neurosurgeons who don't have much experience with it, even orthopedic surgeons who don't have much experience with it, don't think of the sacroiliac joint as a possible source of L5 pattern sciatica, even though it is a common cause of that pain problem. So it can be a little challenging if you don't think about it. So symptoms are pain, usually with movement. What are the causes of sacroiliac joint pain and problems? Well, most times sacroiliac joint problems occur without a known cause. They just come up. So people develop arthritis or wearing out of the joint. People develop inflammation. So that's a very common answer to the question of why do I have this problem. Trauma can cause it. So if the sacroiliac joint has been damaged somehow, either by major vehicular trauma, commonly a fall where somebody falls onto their hip on the side and takes that pelvis, looking at it end on, and twists it a little bit, some of those ligaments can get torn. Another source of trauma is the changes that go on in a female's body when they're getting ready to deliver a baby. At the end of gestation, at the end of pregnancy, the body sends all kinds of chemicals to the skeleton to loosen up the birth canal, to make it so that the pelvis is more flexible so the baby can pass through and go out. Well, what can happen is that can soften up those ligaments and such so much that they don't tighten back up like they're supposed to. And so they allow that joint to move more than it's designed to move, and that can give people lingering pain. So quite commonly, the sacroiliac joint is more common in women than in men, particularly because of that. A lot of people who have an inflammatory type of arthritis, psoriatic arthritis, rheumatoid arthritis, lupus, ankylosing spondylitis, these types of diseases that are joints being attacked by the body's immune system cause destruction of the sacroiliac joint and can cause pain. Some of the more uncommon things are people who abuse IV drugs, who constantly inject themselves, increase their chance of getting an infection in their bloodstream, and that can oftentimes set up in the joints that don't have a great blood supply, and so the sacroiliac joint is one of those areas we see infections. People who have other inflammatory disorders like colitis, ulcerative colitis, or Crohn's disease, they have a lot of inflammation in their body. We commonly will see people complain of sacroiliac joint pain when they're having a flare-up. In the spine surgery world, probably the most common reason that is created by what we do with surgery is when we fuse the spine and put screws into the bones down into the sacrum. If we have to go down there, we've made that area stiffer. We start to see more accelerated aging, wear and tear, and degeneration of the discs or the joints above or below the area of the fusion. Well, the joint right below the area of the bottom disc level is the sacroiliac joint. And so a lot of people who've had spine surgery with fusion down to their sacrum can start developing degeneration of the sacroiliac joint, and that can cause pain. So that's anatomy, that's what the symptoms are, that's what are the causes, what can we do about it? Well, to start off, if people develop symptoms of sacroiliac joint pain, with an evaluation, we rule out the other sources of pain in that area, such as a herniated disc or a pinched nerve in the back, a tumor or a fracture or an infection, something like that. If it looks like it's strictly a sacroiliac joint problem, first step is anti-inflammatory medications and physical therapy. The purpose of physical therapy is to kind of reduce inflammation, to try to get that joint working like it's supposed to. Many times people develop tightness in their hamstrings, their lower back, and so it's an imbalance in their muscular tension in their body, and the mechanics get thrown off. And so physical therapy may not actually be working on the sacroiliac joint, but those structures that are nearby to try to help loosen things up. They can use a sacroiliac joint belt, which is basically a low-slung web belt that kind of wraps around the hips and the pelvis and kind of squeezes the pelvis together to kind of add some support in that area. Injections, steroid injections can be useful in trying to reduce inflammation. Sometimes they can be curative, sometimes they can be useful in diagnosis, sometimes they can be useful in management of the sacroiliac joint pain problems if they're not too bad. There are some other types of injection treatments. One is called Prolotherapy, which is an injection of some saline or some other chemicals into the joint to essentially stimulate healing or reversal of the inflammation by allowing the body to attack that inflammation. There's variable successes in that. And then lastly, there's surgery. Now you can imagine this is a structure deep in the body. It's got lots of ligaments attached to it. And the only way to get there is to really go down deep. And in the beginning of time, way before I started training, people would do open sacroiliac joint fusions. That would either be going from the back and removing those ligaments and grinding out that joint and packing bone material into that joint to allow the body to grow that solid, or essentially tricking the body into thinking it's got a broken bone and telling the body grow bone here. The point of that is to stop motion through the bad joint so it doesn't hurt as much. We would also do it from the front. You can imagine you got to move all the intestines and all the other, sorry about that, all the organs out of the way. There's a bunch of nerves, vessels, and things like that that can be damaged. And those types of surgeries were big operations, and they took a very long time to heal. It would be 6 to 12 weeks of non-weight bearing on that side before people would start feeling better, and it would take a year or longer to get over it. So that really fell out of favor because nobody wanted to go through that. Well, about 10 years ago, and full disclosure, the company that I'm going to talk about was the first primary company to create a new minimally invasive system of stabilization or fusion of this joint. I am on their instructors list, which means that I have on occasion been paid to teach people how to implant this system. I only get paid for the work I do. I don't get any kind of consulting fees or anything like that. And I only do it because I really believe in the technology. So that's full disclosure. But SI Bone is a company from California, and they came up with a technique whereby we can try to stabilize that joint with a more minimally invasive approach. And essentially what we do is, through a small incision in the skin, we insert several implants, devices, metal objects, across that joint. So basically they cross through this bone into the sacrum and basically create a three-dimensional stiffening of that joint. And what that does is it helps to reduce the motion across that bad joint. Eventually, those metal objects, the bone grows onto them or through them to lock them into place. And theoretically, some of the joint becomes fused together. Now, I really tell patients it's more like spot welding the joint rather than destroying the whole joint and fusing the whole joint together. But that stabilization has been a huge improvement in the surgical treatment for the sacroiliac joint. Far less impact on lifestyle, far quicker recovery. And in my experience, personally, and compared to the data that's out there nationally, we typically get somewhere between 70% or greater improvement in the sacroiliac joint pain than what the patient had before surgery. In my patients, for whatever reason, and I don't think it's anything but just good fortune, my patients have averaged somewhere between 70 and 100% relief of their symptoms, more on the top end, more like 80 to 90% or better. And this is self-reported. This is not dogmatic data with regard to critical analysis and blinded studies and things like that. This is my patients telling me how they feel. Be that as it may, the people who've had it done by far and away would say, number one, they do it again. Number two, they're far better than they used to be, even if they still have some pain. And number three, the recovery really wasn't too bad. The nice thing about this procedure is it can be done as an outpatient. We do put people on crutches to kind of limit their weight bearing for a few weeks, and then we slowly allow them to return, and maybe a little variable there. All over the board with regard to what was the cause of the problem. Some were women that had had pregnancy and had pain since then. Some were trauma, falling down typically. I've had a couple of people who had major trauma and disruption of the sacroiliac joint and developed degeneration in scar tissue. And then a fair number, probably 50% of the people have had lower spine fusions down to the sacrum. So my patient population has pretty much mimicked kind of what we've talked about those people who get this. And I've been very pleased. My patients have been very pleased. Complication rates are extremely low. Nationally, having to do it over again, which is called revision, is very uncommon. I think the more you do or the bigger centers you go to, the more likely there is going to be complications, strictly because of the numbers. But it's been a useful tool to try to help people improve. Now, there are other companies who've taken on this type of technology to try to create their own mousetrap on how to manage this. I will say that I think some of those companies' products are probably very good and probably equivalent, if you will, to the success rates of the SI Bone product. However, none of those products have the data, the studies, the patient experience studies that the SI Bone folks do. They were there first. They made it a point to do studies to support the reasons of using this device. Many of the insurance companies have used specifically the SI Bone data to say, okay, we're going to cover this. And many insurance companies actually say, we're only going to cover this minimally invasive procedure if you use the iFuse SI Bone product. So I'm a scientist. I go where the data is. And so, like I said before, even though they have paid me to teach people to do this, I don't get paid because I use it. I use it because I believe in it, and they have the data to support it. I don't have that same level of confidence with the other systems out there because the data isn't out there using those systems. But in any event, I think that it can be a very useful tool in trying to help people. I do have a couple of pictures here, and this is kind of a go back and review. So again, we're talking about the sacroiliac joint. The sacroiliac joint is the joint between the spine bone at the bottom, called the sacrum, and the ilium, which is the pelvis. And if we look here, this is looking at you from the front. So here's the right hip, here's the left hip, there's the spine. The sacroiliac joint is that kind of curved area right there. All those gray things are the ligaments that run across that attach those two bones together. And you can see there's a big meshwork of ligaments in the front. There's also a really strong meshwork of ligaments in the back. Symptom-wise, people typically talk about pain in the back side of their pelvis, above their buttock, into the hip, down low. Occasionally people will say it's my hip. Occasionally people will say it's my back. We kind of do some examination findings to kind of narrow that circle down to kind of center in that area. But people can also have, this is the back of the leg here, people can also have pain that radiates down, typically down the buttock, down the side of the thigh, and even into the side of the calf, down that L5 pattern. And occasionally people will actually have groin pain as well up around their hip. The iFuse system, or any of the other systems really, are meant to try to reduce the motion in the sacroiliac joint. While they're touted as fusion procedures, I'm a little cautious to use that term simply because I don't know how much of the joint actually becomes solid. I think basically we're spot welding the joint. But in the iFuse system, there's these implants. They're triangular in shape. They're hollow. And the reason why they're hollow is the way we do this procedure is we put a pin, using an x-ray machine, across the joint in the right places, and then drill a hole, and then pound these pegs across along that pin down in that hole to cross the joint. The reason why they're triangular is that helps to prevent rotation. So a circle, a cylinder, you can spin around, right? Okay, it's like a popsicle, or a dowel that you're spinning around. The triangle, you can't spin around, and so it hangs onto the bone more. And then the surface of these implants is coated in a titanium spray that allows or encourages the bone that these things are sitting in to grow onto the surface. So essentially interdigitating onto the surface and locking those implants into place. Typically we put 3 implants in. You can kind of see this is a schematic of the 3 implants across the sacroiliac joint. And again, it's an incision about 2 inches long. This is what an x-ray looks like after the fact. And so the bone, the pelvis, is the light gray. The sacrum is kind of this triangular shape area here. Here's the lower spine. These bright white things are the implants that go across the sacroiliac joint. And so, again, the purpose of this type of treatment, if you have to get this far, if the therapy doesn't work, if the injections don't work, if modifying your activities don't work, this type of surgery to reduce the motion of a bad joint can make a huge difference in people's lifestyles. And fortunately, this newer minimally invasive technology really does make the recovery so much faster, so much easier, with I think, equivalent results as the big operations where we're taking out the entire joint. So it's an exciting evolution of the technologies. Does this make people pain-free? Occasionally, yes, but I never promise that. I always tell people it's probably fair to expect some continued discomfort because we're not removing the entire joint, and we are altering the anatomy to the point where we're trading one thing for another. I always tell patients it's like robbing Peter to pay Paul. We're changing your anatomy. We're not giving you new anatomy. We're changing things to try to help improve things. So there are limits to what this can do. But I'll tell you, my patients have been extremely and essentially universally thrilled with their outcomes. So it's an exciting technology that we have to offer. I hope that these patients continue to do well. So again, sacroiliac joint problems are super common, probably more common than we think they are. There's actually estimates that maybe 20 to 30% of low back pain problems are actually caused by the sacroiliac joint. It kind of fell out of favor as a diagnosis because the treatments for it were hard and people didn't want to deal with them way before I started training. Nowadays, we're kind of identifying more patients because we're looking for more patients. So while it's not a cure for every cause of back pain, if you have sacroiliac joint related pain, as best as we can tell, the therapy, the injections, and then finally potentially the surgery can be a big tool to try to help. So think about that if you've gone through a lot, and especially if you've had spine surgery in the past and you're still struggling with pain, again, particularly in that lower back, down low, up around your buttock, and maybe with some pain down your leg. So I think that's it for today. I hope this was helpful. I hope it was interesting. It's an interesting topic for me. It's one of those technologies that came about after I went through training, and it really is just a matter of keeping your eye on what's out there, what kind of things people are trying to figure out to try to help people. We've seen with Dr. Carpenter and his Mako robot that the way technologies can revolutionize accuracy and precision when doing knee replacements. We've seen with Dr. Crook, for example, the cartilage restoration that before we used to just say, you know what, there's nothing we can do, and now we can transplant or replace cartilage and at least buy time of comfort and function. We've seen with Dr. Willis talking about shoulder replacements and rotator cuff repairs, the technologies that have made things more minimally invasive, less intrusive to the body, but more functional restoration. So technology, material science, engineering, all of these things run hand in hand with musculoskeletal care. And it's a pretty exciting time because there's lots of people, companies and whatnot, doctors, looking at newer ways to do the same thing but better and more cost effectively, and also with less recovery and with better outcomes. So it's pretty fun to be an orthopedic surgeon in this day and time, especially if you were an engineer like me who trained way back when I mean, we didn't even have the IBM. This didn't exist when I was in college. The internet didn't exist when I was in college. It's pretty cool. Anyway, so that's it for today. We're trying to figure out what we're going to do next week. I think I screwed up, and we may have had somebody scheduled and I screwed up the schedule, but in any event, I'm going to find something to talk about. We'll let you know in the next day or two, first of the week, about what we're going to do next. We may have a guest, we may not. Comment below. Go to TOA.com. If there's any questions you have, please let us know. If you have any comments, please let us know. If you have any interest in topics, please let me know. I'd love to make this for you, not just for me, okay? Anyway, so that's it for today. I hope you all have a good weekend. It's absolutely gorgeous outside. Please take advantage of it. Go out there, live your best life. Talk to you later.